All right. Good morning, everyone. Depending from where you are following us from, I think we need to start. It's 5 minutes after 11 Central African time. My name is Boniface Kanjere from Zambia, a member of the Zambia Mathematical Sciences Association. I work for the National Food and Nutrition Commission. We are about to start our webinar. We invited Professor Farai Nyamdza to help us with the presentation. I met Professor Nyamdza in Tanzania when I was doing my MSc in mathematical modeling. I actually majored the epidemiology modeling of diseases. So before I hand over to Professor Nyamdza to do his presentation, I would like our president of the Zambia Mathematical Association, Dr. Kelvin Muzundu, to say a few opening remarks before we hand over to Professor Nyamdza. Dr. Muzundu.
I think he hasn't yet joined. What we can do is the prof can go ahead with the presentation. Then if he joins later on, we can ask him to say a few things about the meeting in the end.
All right. Okay, so some housekeeping issues. Let's make sure that we mute our mics, all of us, and then also we turn off our video. That will improve our bandwidth. Then if we have any question or clarification, we need to make sure that we type it on a chat. We type our questions in the chat. So I think we can now start our presentation. Professor, over to you, Professor Nyamdza.
Let me just start by thanking the Zambia Mathematical Association for the invitation. And I would want to also thank each and every one of us that is participating. I am seeing some faces that I had not seen for a very long time. Edward, Mavis, it's actually a great pleasure to have just seeing you once more after a very long time. So what I want us to just have a brief talk about is the mathematics behind COVID-19 modeling. And for your own information, the title might be a bit misleading over basically what I did prepare, but everything boils down to basically the math modeling of COVID-19 currently as things stand. So I will look at a little bit of some intro. Then I only have one objective here. Then I will look at basically a few of the math models that have been floating around. Then I'll look at what we have been doing here in South Africa. And then we'll look at what I have seen on the internet concerning Zambia. And then I will make a conclusion thereafter. So we know that since the emergence of the novel coronavirus, which we call COVID-19 in China, we have seen a global spread of this disease rapidly as a wave from China into Europe, into the US, in South America, now down onto the African continent. And each and every one of these countries have been experiencing the disease at different times, and the dynamics have also been basically amazing and difficult to understand, apparently. So we know that in each and every country, the disease has actually been linked with, actually been linked with international travel. And for many of the countries, you can actually treat your country as a wholly susceptible population. Then anybody who is actually coming in from an infected state or from an infected country would actually bring the infection in that particular country. And we know that in South Africa, the disease came through some guys that had gone for holiday in Italy, and they landed at OR Tambo and ended up in Durban. And this is where the very first case, which we refer to as the index case in South Africa, was detected in March this year, March. And we have also known that in different countries, we also have had index cases at different times. So, you know, immediately after the international travel, there were measures that were actually put in place. And basically many countries had to put some lockdowns, and they had to close schools, and they had to either shut borders. I know most of the interventions have also been targeted at prohibiting unnecessary human movements. And we often see adverts that we need to stay at home and all those kind of things. So we know, I've seen many mathematical models in their thousands that have actually been developed to date with respect to this particular infection. And one thing for sure is I have noted that models are not a report sent back from the future. Basically, they depend on what is currently happening. As I shall talk a little bit later, there is a lot that has also happened with respect to the information. So we construct these models on things that we know and stuff that we think we know, and sometimes even stuff that we have no idea about. And we know that with respect to COVID-19, there is probably a lot, or actually we don't know a lot about the disease. And we, at this particular, what I can only say is, this has actually made mathematical modeling fascinating and at times duplicated in this particular case. Fascinating in the sense that sometimes some of the initial models are no longer valid and some of the current models are, and people are churning out new models as information changes. And we know that according to Box, all models are false, but a few or some are actually useful. And we know that math models can actually help us to sense the world, assuming our assumptions are valid. And the truth is, and this is what is important, we don't need to feed in bad data into the models because otherwise the models themselves will not make much sense. So Box reminds us that mathematics creates a shadow of reality and that the universe is much more complicated than any what our models do suggest. So in essence, I want to focus on simply what is in the mathematical modeling of COVID-19. And this is what my talk is going to be all about. So we know that many of the models that have been studied to date are driven by deterministic models. And the most popular one has been the SEIR model and its variants. And I'm not going to talk about the variants, but I'm at liberty if one wants to. But the foundation is basically the SEIR model. You can input age dependence in there. You can input, meta-population models. You can input stochastic parameters, time-dependent parameters. You can input even some in-host models when you look at models driven at different timescales. So there's a lot of modeling that can actually arise from this particular model, but this has been the foundation of what we have had. So I've also seen a few SIR models that actually came up, and obviously all these models come as, driven by these overriding assumptions that we know about the spread of the disease, which is basically the epidemiology of the infection, in fact, in essence. So we know that in some of the models, depending on what we are using, the data has to be consistently churned out, maybe on a daily basis, on a weekly basis. I'm not so sure. We also know of the incubation period. We know of the duration of infectivity. And of course, currently, the SEIR model assumes that the people that recover become immune to the infection because this has been the structure of many of the respiratory infections. But it has been seen that in some few individuals, some people have actually been infected for the second time and for the third time, depending on, depending on where the research has been done. So, of course, the aspect of homogeneous mixing, now that there's new evidence that is coming up. So the SEIR model basically has this particular structure here. And the structure that is basically here is basically where you have from susceptible to the exposed, you are infected, then you progress, you become infectious, and then you recover. So you can attach mathematical expressions or mathematical functions to each one of those particular processes. And these mathematical functions can actually change depending on basically what you are inputting and what you are modeling as far as the disease is concerned. So apparently when we started looking at the modeling of COVID ourselves, we actually thought that immigration was an important factor, especially between the 5th and the 27th of March, when the borders were closed. We knew people were still flying into South Africa and out of South Africa. So in a way, it meant that the assumptions we had to make here, because every model is driven by some assumption, that we had not have anybody who has recovered or infectious who came in, and everybody who came in was either susceptible or basically exposed. I will show you why we thought of that particular thing. So we actually realized that this data that I'm presenting here is basically data that is from on the South African context. So if you look at the times there on the horizontal axis, the red line it basically demarcates where our lockdown is. And just before the lockdown, we also had closures of schools and some of the other things as intervention measures. And one would assume that if we didn't have a lockdown, then the data was just going to just continue exponentially. But then after the lockdown, there is a new initial condition that was actually started as far as the new cases are concerned, of which the new initial condition started around the end of March, where we also started having maybe some kind of a stabilization, but now we have actually gotten onto the exponential rise in terms of the infections. So with respect to the SEIR model, one can look at the interventions. You know, initially, there wasn't anything like hospitalization. There wasn't anything like some of the things that we are actually seeing right now, where we needed ICU beds and all the other things initially. But now, the only interventions that we had to focus on were issues of social distancing. And of course, the issue of masks became mandatory soon after the lockdown. But there were actually media campaigns and people were actually encouraged to self-isolate. Now, when it comes to some of these interventions, apparently, I'm sure many of you have seen in many countries, our education or our schools have actually reopened, and some of the requirements are that our children need actually to sanitize as when they go into when they go back to school. I want to just show you one small video, and then you will actually see that we actually, in some, when we come to modeling, even if you say our children are sanitizing at school, then you have to think again twice after watching this particular. Right. So apparently, I'm sure you have seen the levels of sanitizing that is going on in our schools and what our children are basically doing. But those are some of the things that we battle with, which models can actually not capture. So with respect to the SEIR model, you can either choose to have your deterministic model, which is continuous, or you can actually use a a discrete model. So I'm going to just change the platforms here. Then I'll get to maybe have an opportunity to actually write, if ever I can. Let me just see whether I get onto this thing here. Right. Okay, good. So in essence, so what it basically means is, as far as our continuous model is concerned, we can actually see that this here is basically the driver of our infection, both in the continuous case and in the discrete case. So we can actually play around with this particular model depending on what we basically want to model. But this is the foundation of our models, both the continuous and the discrete ones. Now, we actually at one point looked at the aspect of social distancing, and this is how we actually factored in social distancing. We actually say instead of having beta IN, so distancing, and one means actually a total blockade in terms of the infection. But in this case, one would say maybe the best is maybe not to include this as a closed interval, but maybe an open interval. This is basically what I would probably suggest. So whenever you're looking at just inputting the aspect of social distancing on the SAEIR model, you would probably just modulate by simply saying social distancing minimizes the rate of infection. So let's look at what would, if you now want to incorporate the aspect of masks, you could even add an additional parameter Q, where of course here, the P and P still measures the effectiveness of your social distancing, and your Q measures the effectiveness of your masks, where Q equal to 1 means masks can prevent infection 100%, and when Q is 0, it simply means there are no masks at all. So you can either do the same both for your discrete and your continuous model. So you can also look at the aspect of behavior change. And this particular thing, this particular function I put here is the function, the exponential of e to the minus alpha I, where you actually say individuals change behavior by looking at the number of infected cases. The higher the number of infected cases, the lower the infection rate is going to be. And you can also do the same for your discrete case model. And apparently, I have to mention that this model in which we have behavior change is usually the one that will give you peak number 1 and peak number 2 as you continue, as you model your epidemic. So you can also, I've seen people advocating for vaccination. Remember, we can also model for things that we anticipate and where we want to look at vaccine efficacies and how the vaccination would actually do. So in this particular example here, you could, depending on how you want to.
Professor,
yes.
Professor, yes. The slides are not moving. We are not able to see.
Oh, is it?
Yeah.
Oh, okay. Okay. Let me just let me just get back to what I originally had.
All right. Okay.
So is this okay? That's
yes,
fine.
Yes, it's fine. It's fine.
Okay, good. So you can actually have your you can actually model your infection. This is basically the issue of modeling behavior change. So you can actually see that as I increases, the infection rate also decreases. So we're actually saying as the number of infected cases increase, people tend to have to actually have some kind of a modified behavior, resulting in some reduced transmission in the process. So you can also look at vaccination as far as the whole thing is concerned. You vaccinate at a red K, and whoever is vaccinated goes to the removed compartment. And you can also use, create another compartment of the vaccinated, and the model will have a slightly different structure here. So the mathematics that can be, that we can talk about at best can be described as basically a dynamical system. And we are always interested in the existence of solutions, their boundedness and their positivity. And I have to mention that many of the models that we have actually seen have actually lagged part of this, that people are just putting models there, but they don't check whether these models are feasible biologically or whether the solutions are actually bounded. And some of the predictions are actually very, very difficult. I will mention one classical example. So, in essence, with the SEIR model, the way I've presented it, we cannot look at the long-term dynamics of the epidemic, which means we cannot involve aspects. I mean, we can, but aspects of steady states might not have much of a meaning in this particular case, because steady states represent the level of the infection after some time. So we can also look at analytical solutions at this particular model if ever we can get them. And of course, because this is derived from the Kermack-McKendrick model, so it is actually something that falls within that particular framework. You can actually find analytic solutions to this particular problem. So one of the things that we can do to this particular model is actually to fit this particular model to data. And for your own information, this is work that I'm actually doing with one of my PhD students. And what we are basically doing is creating some Excel spreadsheet for our data on a daily basis for the different provinces and for the total number of cases on our for the national cases. And we also have the number of new cases and the number of recovered cases. Now, the good thing is data in South Africa is actually coming on a daily basis. So using a discrete model, it's actually easier because you have discrete time steps that you can actually, that are almost uniform in this particular case. Now, one of the things that we have also seen is that when you from this particular spreadsheet, you can also generate the number of new cases. And apparently, if you look at where my cursor is, this is where we had a slight blip in terms of the number of infections. Then they went down again, but now we're actually seeing an exponential rise in the number of new cases. And we then actually, as of 7th of July, we actually had to fit the number of new cases in this particular case, our model, and this is the fit that we did obtain. And of course, we can actually use the very same model to actually make some projections. And in this case, we made a 15-day projection, but we make the following assumption that the epidemic continues to grow at the current rate. And the conditions remain the same, interventions remains at the current levels, but we definitely know that the economies are basically easing up. People are going back to work. That has got an impact on the way the epidemic is actually evolving as we sit. And apparently, we have just been told that today, as of the last 24 hours, we have just had another new record in terms of the spike in the number of cases. So this is the model that we got when we made our projections, that we will have maybe daily cases of around 16,000. But the ones that we have today are already around 13,000. So we are expecting that the number of new cases might actually continue to actually rise a little bit, because we are still on the exponential side. And we did some even projections that actually led us to some very fun result that as far as this province, which is the Gauteng province, Joburg and Pretoria, we are likely to have our peak not in the projected September, whatever, but around early October or somewhere there. But again, this is under the assumption that the epidemic remains, or the interventions remain at the current levels, and people behave exactly the same as they are behaving now. So some have also modeled the early dynamics of the infection, and in modeling the early dynamics of the infection, they've actually used some exponential growth functions, and some of them have actually used logistic growth functions of this particular nature with these particular solutions to model that exponential rise in the new epidemics. So we can also look at the 95% confidence interval, and this is actually the cases in the Gauteng province, and we can actually see that we are projecting that by the end of the month, we will actually get to around, we'll be actually hitting 20,000 cases, looking only at the early transmission, assuming that things or the epidemic continue to be rising exponentially in this particular case. So let's also just move to the case of Zambia. I went to Worldometer and actually looked at the daily cases of Zambia, and I've actually noted that apparently the data from Zambia of the new cases seems to be, it has quite a lot of noise, and there are actually some other days in which actually there are no recordings of the data. And I've actually checked, even for Zimbabwe, it is exactly the same, that you have cases or times when you don't have data that is being released. And in that case, that actually also influences your modeling and the type of model that you would actually propose for this. Then I've also seen that there was also somebody, I'm not so sure whether you know these two guys, but I've just put their names because their work is actually in the public domain. If it wasn't, I wouldn't have put their names. Apparently they used the SEIR model, and one of their projections was that if you look at the very first diagram, that this peak here for South Africa was supposed to occur on the 1st of July. But apparently, this is not exactly what is happening. So on the SIR model, there is something that the model did not take into consideration that actually said the epidemic is going to be, we are going to start having a decline by the 1st of July, when this is the time we are actually having our steepest rise in the terms of the number of new cases. But of course, this model, it doesn't mean that it is wrong. It was based on the assumptions that the researchers basically used. And for Africa, they also predicted almost the same, that Africa will reach its peak on the 1st of June. And of course, we are still very far away from that, according to what we know. So one thing for sure is we know that models are actually dynamic. And the pandemic, as the pandemic evolves, models must be adapted to track the new developments. And one of the new developments that I have actually seen, that we know that new information on the virus emerges every day. And I had this very funny thing that I actually saw. Somebody actually, I'm sure I'm not going to say it, but some of you can read it. That, and according to numerous reports, and they actually said, yes, the COVID can actually be spread this way. And I'm not so sure whether that information, of course, has since changed. So you need to be very careful of what to me, it actually made it very funny that COVID can actually be spread by gas in the presence of other people. But anyway, that's a different story. So most people who get, what we know influences the models that we have been doing is that most people who get COVID-19 will have mild symptoms. And some of them, they recover without needing any professional medical care. And we know that around 8 out of 10 people, which means 80% of COVID-19 people, will only have mild symptoms. The only ones that will have bad symptoms are only 20%. And around 1 in 6 people will become severely ill and they need hospital care. And we know that, which means scientific modeling suggests that 1 in 100 people will die of COVID, which means this is basically 1%. This is what is basically coming out. And we know that most recently, there are some scientists that wrote to WHO that apparently transmission is now actually thought to be airborne, which basically means that even our models must actually capture the fact that it is now airborne, apart from it being spread from surfaces and from the environment, or from some coughs, or from some talking, or from some particles that are released in the air. And I know some people in physics have, or in fluid mechanics have even released the distance that these particles would travel when one speaks. Now, we know that many people have gone, this is one of the things here in this particular slide, I'm basically going to talk about my biggest worries. That we do have many people that have gone into modeling, but without the critical foundational skills. And by critical foundational skills, I mean basically because if you are developing a mathematical model, you need to have the correct mathematical background and mathematical foundation for you to be able to actually model successfully and model properly. So I've seen some people that are just drawing compartments and then that's it. So models basically, as I've alluded earlier, they need to be biologically feasible. So you need to understand that bad models basically give bad predictions. And also bad data leads to bad predictions, even if the model is good. So in one way or the other, this encourages basically those that are dealing with data to give an opportunity to those that are good at the modeling, so that they can work together, so that the models will be meaningful and the data will be good data, so that even our predictions will be good predictions. Now, I want to draw your attention as I come to the close that with the case of Gauteng, there's something that came on our news. I don't know whether this is happening in Zambia or in some other countries, but something that happened came out of the news recently, that the province had actually, designated a place where they were actually digging 1 million graves in preparation for the rise in the number of COVID deaths. Now, one would then say, from a mathematical point of view, if we say scientifically, our death rate at the present moment in South Africa is around 1.6. And on average, if we say it is at 1% or at 2%, whatever it may be, let's take for mathematical, if we want to take it at, let's just put it at 1%. What it would mean is that if you dig 1 million graves, your assumption is that you will have about 100 million cases. And once you say you will have 100 million cases, when your population is actually 58 million cases, then we have a problem with the prediction. Personally, I will have a problem with the prediction. Now, even if we say the death rate is at 3%, but for a population of 15 million in Gauteng, 1 million graves, come on, that's quite a lot. But anyway, maybe somebody got a tender because we saw some excavation that was going on. And I think that guy was charging, maybe if he was charging 500 rands per grave, then he will end up with 500 million in his pocket. Anyway, that's a different story. So as the epidemic progresses, we know that hospitalization has become an important thing. And some people have also tried to look at the issue of ICU beds. Then in this case, you might need then to have to include some additional compartments. But remember, this is still the SEIR model. So however, in this model, you have what we refer to as your asymptomatic cases and your symptomatic cases. But some of the symptomatic cases are actually undetected. And the screening process, or the mass screening and testing, is basically to root out the undetected infectious cases. And this is what has actually given rise to some of the numbers that we are actually seeing. And whenever you have detected cases, they can then be hospitalized. And after being hospitalized, a proportion of them will actually need ICU beds. They become critical, and the other proportion may actually recover. And we also assume that those that get into ICU, some of them may actually recover. And those that are undetected that actually even recover without being detected. So this is an extension of the SEIR model, looking at the fact that you can actually adapt that model depending on what you are investigating and what your objectives are with respect to the epidemic. So I will end here, and I would want to thank ZAMSA for the invitation. And as the former ZAMSA president, I would want to take this opportunity to actually encourage every establishment within our very own countries to establish national associations such as ZAMSA, so that we have some interactions, such as these, that are being brought, or these opportunities that are being brought by COVID-19 into our fold. So I would want to just encourage you guys to, if ever you are in Zimbabwe, form ZIMSA. If you are in Botswana, form BOMSA. If you are in Namibia, form NAMSA. If you are in Kenya, form KEMSA, whatever it may be. If you're in Tanzania, form TAMSA, so that at least we have greater interaction within our establishments. So I'm very sure that many of you had to assume that the person you are listening to knows something that you don't know. That's basically the reason why you were listening to me. Thank you so much. I really appreciate it.
Thank you, Professor, for that good presentation. Now, I can't see any questions in the chat. I don't know if we can, okay, we can raise our hands and then we pose the question. If there are any reaction, compliments to the professor for his presentation. Any questions?
I can see some hands.
Okay. Okay. We'll start with Eduardo.
Yes, thank you. Thank you very much, Farai, for this fantastic talk. It's been very interesting. I have a question about when you show the fit of the model to the data. How do you account for underreporting of cases? So how do you account for the cases that you are not detecting just because there's not enough testing, for instance?
Apparently, in this particular modeling framework, there wasn't anything that was input in the model per se to actually account for the underreporting. But if you want to account for the underreporting, then you might have to actually reframe the SEIR model into the last model that I showed you that had undetected cases. Then in that case, then you can be able to then say how many of these have we not detected based on what parameter values and your time series plots that you get from that particular model. But there isn't anything that has been put in the SEIR model. What you're simply just fitting are basically your infected cases to the data in this case.
Yeah. Thank you.
Okay, and then maybe, Professor, we can handle the questions in the chat. The first one is written to me privately. It says, I clearly see that the projections made using the model are in agreement with the reported data. Is there any consideration for infected cases that have not been detected or reported? This is coming from Bob Senyage.
I think my answer would be exactly the same as I've just given to Edward. Because in this particular case, remember, the modeling framework that we have only has the susceptible, the exposed, and the infected, which means within the modeling framework, we only have the model is considering only those that are basically infected and not really looking at that are detected, not looking at the undetected, which is again one of the flaws of the model itself, which means there is actually a need to actually re-look at the model, to actually look at the other 20% that are actually undetected as part of this particular model. Okay,
there's a question from William Chuku. He says, does continuous and discrete models give similar projections or any epidemiological data prediction?
As long as you use the same parameters, they should roughly give you the same thing. But you need to understand that with your discrete models, remember they are actually looking at, you're actually saying the number of infectives tomorrow will be the number of infectives today plus the new cases that arise in the 24 hours or whatever time frame you are actually using. But in terms of the predictions, they should actually give the same, but of course with some margin of error, because with the continuous case, remember with usually continuous differential equations, the time step there might actually not be exactly the same as the time step that you would use on your discrete models. That differences in the time steps can also create differences in slight differences in the predictions themselves.
Okay, then we have Suleiman Sani, who has his hand up. Suleiman can go ahead.
Okay, thank you very much. Thank you, Professor, for this wonderful lecture. My question goes like this. At the moment, do we have a probability law, for example, governing any aspect of COVID from the mathematical perspective? And again, do the probability laws of past epidemics, for example, have any role to play in the understanding of this current COVID-19 pandemic?
Okay, so Solomon, I didn't get you said, do we have laws that say what? Sorry, you might need to increase the volume a bit.
Okay, Prof. What I'm asking is, do we have like established theorems in pure mathematics that can explain anything about COVID at the moment?
Oh, you mean stability theorems?
Yes.
Not any that I've seen, but remember, you know, if you include the vital dynamics in this particular model, that means your recruitment, your death rates, and your mortalities, and all these other things, and you look at the disease over a very long period of time, then sure, we can then have we can now talk of stability. Epidemic is still ongoing, so you can't have sort of like any stability theorem that you can actually establish as of now. But apparently, I've seen a few models that have included the long-term dynamics, which includes steady states, and then they include those stability theorems.
Okay, thank you very much, Professor.
Sure. Okay, then Innocent Maposa, you can go ahead and ask your question.
Thank you, Boniface, and thank you, Prof Nyamdza, for the presentation. It's very enlightening. especially the Gauteng kind of case where they are preparing for million deaths already, when, I mean, the numbers doesn't really support that kind of thing. So I was just, from my other readings, I have noted that there is some kind of literature that speaks of the efficacy of basically modeling the dynamic R0 or the real-time R0 in conjunction with these SEIR models. What would be your take on that, and have you tried to do that for South Africa?
You know what? That's a very interesting question. Apparently, I belong to the Gauteng provincial government COVID-19 grouping. We actually have somebody who is actually looking at how R0, the time dependent R0, the time changing R0 is. We're actually having somebody who's actually looking at that. But I personally actually haven't looked at that. But apparently we do have somebody within our group who is actually looking at how the reproductive number has actually been changing depending on the various divisions of the Gauteng province. Apparently it has also been divided into several sub-districts. And he has been looking at how the R0 changes with respect to time within each particular district. And this has actually been a very interesting thing, because you can actually see how the hotspots have actually been evolving over time as the reproductive numbers have also been changing.
Okay, we can go to Dr. Okay.
Oh, thank you so much. Thank you. Can you hear me?
Yes, you can go ahead now.
Thank you for the presentation, Prof. I have two questions. The first one is this. You mentioned something about wrong data. Now, how can we avoid the wrong data? Because remember, we don't have power over this collection of this data. It is what the government reports to us. That's what we use. That's one. And number two is, the models are out there. A lot of models are there. Is it the right time to be looking at optimal control of all these models? Thank you.
Right. Pleasure. Right. The good thing is you mentioned about the issue of wrong data. Apparently, there is actually nothing that you can do with respect to the quality of the data, except that whatever research or contributions you make, you actually continue to stress that the quality of data is actually an important part. Now, if I can give you an example, some of the data that you see being released today is of tests that were submitted a week ago or 2 weeks ago. So the speed of release of the test results is also basically an issue. So apparently there is very little that we can do, except that maybe to factor in the model, that element that your data may actually be only correct to this particular, you have 95% confidence in this particular data. So with the data, there is nothing that you can do much to it, except maybe advising, or maybe just looking at or taking some confidence interval. So again, I agree with you on the optimal control part of this particular thing, because remember, there are so many of these intervention strategies that are being put out there, and some of them that were used in China may not be useful in South Africa. For instance, we have got this issue where we have been saying people must wash their hands regularly every 20 minutes. What would you do to a school that has no water, or to a place where there is actually very little water, where they actually use what they have they use what they've bathed with to do their gardening, and they use whatever, there's all these other things. And I know places that are maybe in the desert, even in Namibia, they recycle quite a lot of this. So it's you know, these days, the issue might actually be some of these controls may be place or geographic, or, you know, they need to be specific, but the issue of optimal control could be our next phase in terms of the epidemic models, now that at least we have got more of the information that is actually coming up now.
Okay.
Find a new optimal control model.
Okay, Prof, we have a number of questions in the chat.
Okay.
Maybe we can start with the one from Peter Tega. Peter Tega says, some studies says that COVID-19 has originated from other pathogens. Is it possible to incorporate the pathogens in the model?
I'm not so sure what he would mean when he say it originated in other pathogens, but maybe I think maybe he's basically saying maybe COVID-19 could actually be an environmental component, which means if ever it has an environmental component, yes, it is actually important to, if ever you are looking at that thing as if you deem that the environment has got an essential, is an essential part in terms of the disease transmission, then you can actually incorporate it. But the biggest challenge we actually have now is that not much of it has actually been quantified in terms of its.
Hello, we've lost you, Professor. We seem to have lost our speaker.
Chair, can I make just a few comments?
Yes, you can go ahead. You can go ahead.
And you can share that with Professor Nyamdza when he's back.
Yes.
I'm Jean-Luc from the University of Pretoria. I think that I must congratulate you on organizing this presentation, this talk, where people from different countries are put together around this COVID-19 pandemic. And I think that we should continue with this and extend it even to SAMHSA and make it a regular event. I think that it would be very good. I have one comment which I wanted to make, but I can discuss that with Professor Nyamdza at another stage. You will see that in his model, he tried to put on the force of infection, the parameter lambda. Is putting beta time e to the power minus alpha I. So what it means actually is that is trying to reduce the contact rate. So he's trying to reduce the contact rate, and if all interventions are implemented, then the contact rate will go down. And therefore the basic reproduction number, it can happen that it is less than 1. And if it becomes less than 1, that will give an answer to the question which Sunny was asking. So the basic reproduction number at some stage will be less than 1, and therefore you can have a stability result, which says that the disease-free equilibrium will be locally asymptotically stable. So this can happen. But my question is just that the way it seems to me that the parameter, the factor e to the power minus alpha I, that way of reducing the basic production number exponentially, it seems to me to be too strong. And I don't know whether what is happening in the real in practice. I think that reducing the contact rate in an exponential way, I think that is, I would like it to be like that, but I think that it is too strong. So that is, these are the two comments which I wanted to make. But thank you very much and congratulations. You must continue with this and contact all the different mathematical society association which we have in the region. To maybe you must do it on a rotary basis. Today it is Zambia. Maybe tomorrow let us make South Africa do it, and then after that it will be Botswana, and then Zimbabwe. Then we will have events on a regular basis. But thank you very much and congratulations.
Okay, thank you very much. I think we've completely lost the speaker. So what we could do, I think, Moses, we need to just close. So thank you very much, everyone. I will hand over to Moses Mwale. Moses Mwale is the Vice President of the Zambia Mathematical Association, to just say a few words before we close the meeting. Moses, over to you.
Okay, thank you so much, Boniface. And it's unfortunate we've lost our professor, but I want to thank him for giving an insightful presentation on COVID-19, the mathematics which is behind it. I think that this is a very exciting time for mathematics. The virus, there's a lot of things which we do not know about COVID-19. Our health experts, a lot of things which they do not know. And so this is the time we can take advantage of, so that we can do experiments, more experiments, and the experiments come in the form of models. So there's a sense in which, there's a feeling which I have that we're a bit behind as a country in disease modeling, but that may just be because we do not know who is doing what. And so that's why ZAMSA is there. ZAMSA was created to really promote mathematics throughout the country, whether it's pure mathematics or applied mathematics, for people in academia, people in industry, so that we can all come together, we can interact and see what, at least have an idea of what people are doing, the research study which is being done. And I'm excited that we have got a very good participation from members of SAMSA, and we can connect not only among people in Zambia, but all over the world, actually. If there's any help, any gaps which we need to fill, I think we're placing ourselves in a position where we should be able to do that. So thank you so much to all the participants for joining us this morning, this afternoon now. We do have social platforms, so let's not stop the interaction here. If there's any questions, you can always ask on our LinkedIn platform and our Facebook platform, and we can continue interacting as an association. So thank you so much to everyone, and I will just hand back over to Boniface.
So, yeah, sorry, I was muted. So those of you who are asking if we could share the slides, yes, we'll definitely share the slides on our social platforms. Moses will guide on how we are going to share. We'll ask Professor to share with us his presentations, and the recording of this presentation was recorded. We can also share the recordings. So thank you very much all for attending our presentation. This is the second in a series. We're really very grateful as ZAMSA. Thank you. Bye-bye.
Okay, well.